afternoon, everyone, and welcome to our joint pain virtual seminar. Thank you for making your health a priority and joining us today. My name is Kayla Meyer, and I'm a marketing specialist for Franciscan Health. To begin, I'd like to share a few housekeeping items. Everyone is muted upon entrance into our virtual event. We ask that you keep yourself muted to help us avoid background noise and interruption. If you have any questions you would like to ask the presenter during our presentation, please enter them into the chat window. We will address those questions after the presentation. Kirsten is taking care of everything technical on the back end, so if you have any issues during our session, type them into the chat box and she will help you. If you miss anything, don't worry, we will send out the on-demand recording when it is available. If after the presentation you feel like you are ready to schedule an appointment with one of our surgeons, let us know in the chat and you will receive priority scheduling. Before I introduce our speaker, I'd like to give you a little background on the Franciscan Health Center for Hip and Knee Surgery. The center was founded in 1986 by Dr. Merrill Ritter, and it was the first center in Indiana to specialize in joint replacement surgery. The center performs over 2,500 joint replacements each year and is recognized as a leader in joint replacement surgery, treating patients from all over Indiana, the Midwest, and the nation. Our surgeons have performed more than 40,000 joint replacements over the past 30 years and have instructed hundreds of surgeons in the latest techniques and methods for implantation of joint implants. Franciscan Health Mooresville, home of the Center for Hip and Knee Surgery, is ranked #1 in Indiana for patient safety and joint replacement. This is an award that our surgeons, their teams, and all of us here at Franciscan are very proud of. Our speaker today is board-certified orthopedic surgeon, Dr. Robert Malenzak. Dr. Malenzak received his medical degree from Duke University School of Medicine. While there, he also served his orthopedic residency. He has fellowships in joint reconstruction and sports medicine from the Center for Hip and Knee Surgery in Mooresville. Dr. Malenzak specializes in joint replacement of the hip, knee, and shoulder. Please welcome Dr. Malenzak as he discusses arthritis and both surgical and non-surgical treatments for joint pain.
Hi guys, thanks for coming. One of our first virtual visits. We've done a few of these, and yeah, please send in your questions. We thank Kayla and Kirsten for all their hard work getting this set up. So in case, I know most folks might be up in northern Indiana or near Lafayette, but we're down here in Mooresville, which is just south of the Indianapolis International Airport. Not too far from Lafayette. I just drove by there yesterday. Next slide. And as you heard, yeah, we over the 20 years or 18 years I've been here, and even before, the hospital in our group is down in Mooresville, at least, have been ranked #1 in various things. And one of those is safety and outcomes and overall joint replacement. Next slide. So today I'll try to touch on some important details, but I want to make sure we have time for your questions. We'll review what arthritis is, the non-surgical treatments, as well as the joint replacement itself, and then hopefully have a good amount of time for questions for you guys. So what is arthritis? Well, there's many a definition, but it's inflammation of a joint. And we have, our knuckles, our knees, our shoulders, neck. And in that inflammation, in America at least, it's up to probably 50 million folks a year have some sort of arthritic condition requiring treatment. We often end up with decreased motion. There's pain with movement, and the joints will feel stiff and swollen. Here on your left is a arthroscopic image of what cartilage looks like. And I like to say it feels almost like the hard-boiled egg, the white part of the hard-boiled egg after we take the shell off. And just so you know, that probe that's on the picture is 1 millimeter by 5 millimeters for some perspective. On your right-hand side, those little loose flakes you see floating around, that's actually cartilage that's deteriorated off the bone. And once cartilage comes off the bone, it doesn't stick very well. It won't go back very well. Next slide, please. So the symptoms of arthritis, we often end up with pain. That's the #1 reason we see folks. But as we mentioned, stiffness, swelling, deformity. Some folks will come in with the bowed knee or the knocked knees. One of the first signs we'll see is limp. Walking around the grocery store or church or at the baseball game, we'll see folks limping. But the number one reason folks end up coming to see us for the discussion of surgery is when their quality of life has been diminished significantly. The most common types of arthritis are osteoarthritis, which, as my dad calls it, he's the getting old arthritis. There's rheumatoid arthritis, which medications are very helpful and the rheumatologists do a wonderful job. But sometimes even those folks end up with the bone-on-bone arthritis. There's post-traumatic as well as inflammatory arthritis and even osteonecrosis, which is often called avascular necrosis. And we'll touch on that a little bit too. So on your left-hand side of the screen is a knee with the femur at the top and the tibia below. And the space you see in between the two bones is your cartilage. That's what it would look like on x-ray. And that's a relatively good looking x-ray. Whereas on your right, particularly on the right half, you'll see where the bones are touching. That's the bone-on-bone part of severe osteoarthritis. So the goals of our treatment, whether the treatment's surgical or non-surgical, is to help a patient's pain. We want to keep you active and keep your lifestyle active, which obviously has ramifications for your cardiovascular, your pulmonary, and other parts of your health. Next slide. So conservative treatments or non-surgical treatments include, but aren't limited to, things like your diet, your exercise. We've learned that certain parts of our diet can cause inflammation, physical therapy or working with a trainer, yoga classes that work on stretching and balance, medications, supplements like glucosamine, bracing can be helpful. When we get really advanced arthritis, often a cane will be helpful. And then remember, rest and ice can be helpful on a very painful day. Like I just saw a patient that was out raking some leaves yesterday and was very sore today. Well, the rest and ice could be one initial option. So the exercises we advocate, there's obviously some specifics here, but things that work on balance and flexibility are very important, and obviously some strength and endurance. Water therapy and chair yoga are at the top of the list, but things like cycling or rowing, anything that's convenient and fun are what we have found that patients will do more often. The medications that a lot of us know about are aspirin to Tylenol to ibuprofen. These are the most common over the counter. And obviously every medicine has side effects. So we encourage you to always check with your family doctor before adding too much medicine. The two main types of injectables that we'll consider are cortisone or what we call a lubricant. The lubricants they have other nicknames like chicken fat or rooster comb or jelly shots, and there's different brand names. The lubricants often come in a series of injections, anywhere from 5 to 3 shots given weekly. And Synvisc is one brand that actually has just a one-time shot. Though we're not trained on a couple of these on our screen in medical school, I've had a number of patients say that these can work for them. And again, whatever works for you is fine by us. But we've heard acupuncture, massage, magnets, bracing, and even orthotics that go in our shoes. But again, these might not have been studied quite as well, and it maybe won't work for everyone, but certainly they're ones to consider if you're interested. So what about joint replacement? When should we think about a replacement? Well, when pain is negatively affecting our daily living. And if we're bone on bone, then replacement's at one of the top of the list. But mostly your quality of life is what's most important to us. So the benefits of considering or having joint replacement are that it's very reliable in helping eliminate or significantly reduce joint pain, improve movement and mobility, and most importantly, to help your quality of life. So here's a cartoon sketch, one of Dr. Ritter's initial ones from years ago of the hip joint. You can see there the pelvis and the nerves and the muscles, and then the hip socket. On your left is an x-ray of hip that has a space or a cartilage space between the femoral head and the acetabulum. And on your right is where we have what's called a severely arthritic hip, the bone on bone. And I call that the flat tire. You can put air in it, but that tire, you're riding on your rims more or less. So implants, when we do hip replacement, here's some images of what it looks like. There's an acetabular shell with often a plastic liner that's snapped in. And then the femoral stems, most of them are titanium. There's some nuances to the shapes and designs by each company. So when we do hip replacement, picture 1 there, you'll see the femoral head is removed. In picture 2, we put a stem down the femoral canal and a liner or a metal socket up into the acetabulum. And here's sort of a radiographic imaging. In the old days, the picture on your left, we would take measurements of our hip replacements, and on the right are the implanted or the implants that are inside the hips. These days, we use the computer assisted quite a bit to help us with picking what size implants would be best for you. So hip replacement takes about an hour. Recovery room, folks end up being there for 1 to 2 hours. Most patients spend a night and go home the next day from surgery, but I tell everyone, you go home from surgery when you're ready. You don't go home just because it's the next day. Now, in the light of COVID and actually the past 6 to 8 years, we've been leaders in even same day replacement where patients are healthy and safe enough to go home the same day. But that's not for everyone, but that's certainly something in Mooresville we've been able to specialize on. And we've taught several other surgeons those techniques and what patients might be best to consider. So after surgery, the first couple weeks, most of us would ask that you stay on crutches or a walker to let your muscles and tendons and bone and skin heal. Now it takes a year to fully heal, but that first 2 weeks is very important. But within 2 to 8 weeks, most folks are walking unassisted and back driving and going to the garden, or some guys like golf or ladies like golf or tennis. Those are reasonable things to consider near the end of the 2-month mark. So in that 2 to 3 month mark, 1 to 3 month mark, back bowling and dancing and swimming. But again, remember, it's not like one day you're totally better. It's incrementally we improve over time. So the longevity of hip and knee replacement, there's been numerous studies out there, but most would say that you have a very good chance of having a 90% have your hip and knee still in you 20 years down the road. The major complications are listed. Any complication to us is a no-go. We try to avoid every one of them for every patient. And this brings up the concept of the stronger you as a patient, the stronger your legs and your hips and your gluteal muscles are, the better your balance is before surgery. That can pay off with improved outcomes after surgery. But the major complications, as you can see here, are infection to diabetes and obesity. And a lot of these are things we try to address and optimize ahead of time. And that was a whirlwind through hips, and we'll go through knees and then briefly shoulders. So here you'll see the femur on top, the tibia on below, and the ACL right in the middle of the knee. So for the knee arthritis, what happens is the cartilage space diminishes, the bone spurs get bigger, and then the ligaments, the main ACL and sometimes even the PCL ligaments will deteriorate over time. And so here's a cartoon or the side view of a knee replacement with the femoral component and the tibial component, and you can see the back of the patella on the left. And on the right-hand side of the screen, you can see what an implanted knee replacement looks like. And again, so we use the computer a lot these days to help us figure out what sizes to put in. And on your left, you can see the severe bone-on-bone arthritis. This is one of my favorite patients. He was a farmer. He had the very bowed knees, and he used to tell me that he couldn't stop a pig in a ditch. because his knees were so bowed that pig would slip right in. And this was a fellow we actually did bilateral same day knees on. And those are the pictures on your right. So again, the surgery and afterwards is very similar to hips. It's about an hour surgery for one knee. Most folks spend the night and go home the next day. And there are same day options for certain folks that are interested. And so then in knee replacement, there's even partial knee. It's when the bone on bone is just in that, like Kayla just pointed out, that inside or medial half of the knee. And so not everyone's a candidate for partial knee, but if you are, we, the surgeons, will certainly bring that up as an option for you. So the candidates for partial knee, it's listed there 5 to 10%. It's probably more upwards of even 20 to 30%, but it's a discussion between you and your surgeon to see if that particular operation makes sense for you. So again, partial knees, very similar outcomes to total hip and total knee, over 90% success at 20 years in most studies. And finally, I know we're the Center for Hip and Knee, but we do have shoulder experts as well. And here are just some pictures outlining a bone-on-bone shoulder on your left, a shoulder replacement in the middle, and then a cap replacement on your right. So after surgery, hips, knees, what have you. Restrictions, we usually ask you not to do running as a hobby. Maybe don't run a 10K, don't run a marathon. Any high impact activity can affect your implants. But I will say that over the decades and years, and studies are still forthcoming, there are patients that have done these activity, but maybe they're doing them against their doctor's advice. So in the end, I share with you a humorous cartoon that my grandmother sent me years ago. And so if you have severe arthritis, don't wait, at least gather information like you're doing today. It's important to be comfortable with what you're hearing and understanding. And as my grandma used to say, this is some ladies sitting around the dinner table waiting for the perfect man. And I don't know if that shows up on your screens, but it's more meant as a joke to, if you need information, that's what we're here to hopefully provide for you. All right, and that's our motley crew. I love all these guys. The three of us are down in Mooresville, and Mooresville is the center where, us along with the hospital have been the #1 center for decades, is what it seems like now. Yes, and so there you have the appointment number if you ever need anything. And I always give out my nurse Kelly's number just in case no one's answering the other phone. So Kelly is 317-834-5141, and she sure does love getting phone calls. Kayla and team, I know that was a whirlwind through hip and knee replacement. We could talk for hours or days or weeks, but I hope that made sense, and maybe we can get to your questions.
Yeah, that was so great. Thank you so much, Dr. Malinczak. That was a perfect overview. The first question we have is about recovery time, and is the recovery time the same for a hip and knee?
That's a great question, and we get that. Heck, I just had that 30 minutes ago in the office. And the recovery time, big picture for you as an individual, depends on the strength of your legs ahead of time. So the stronger your thighs and your gluteus, the quicker most people will recuperate. Now, to your question about hips and knees, most of us would say hip patients recover quicker than a knee patient. But again, that depends on you as the human and the strength of your thighs and your gluteus muscles.
So is there anything they can do before surgery to help, prepare for that? Do they need to go to PT or anything along those lines?
Great follow-up. And I'm an advocate of pre-surgery therapy, or what we call prehab, whether that's with a therapist or a trainer or on your own. Some folks find chair yoga very helpful. Other folks have water therapy. So anything you can do that works on your leg strength ahead of time is very helpful. Now, we know your legs hurt. Like, let's say you have 2 bad knees. Well, it's hard to do every exercise, but any one thing you can figure out to do is helpful. If you can do 2 things, that's more helpful. Just figure out what you can do.
Right, that makes perfect sense. Our next question starts with a comment. I'm scheduled to get injections here in Lafayette next month, but I want to talk about knee replacement so I can plan. Do I need to wait a certain amount of time after my injection to schedule my first appointment in Mooresville?
Good question. For appointment scheduling, no, we can discuss anytime. And that's great. If you have someone local that knows and likes doing shots, that's perfect because that's more convenient for you. Now, I will say, if you're going to have surgery, you want to wait at least 2 months from injection to surgery. Some docs say 3 months. I've heard some docs in the state would like you to wait 6 to 12 months from the time of your shot to when you have surgery. But visits and discussion, that can happen anytime.
Okay, and this participant says, I know it may vary, but what is the time constraint for someone to go back to work after a knee replacement, specifically for someone who is on their feet a lot at work?
Good question. The average, so we've looked at, Dr. Ritter looked at this in the past and we've done it recently. The average return to work is about 2 months. But remember, the average includes all our patients, folks that have sitting down jobs to folks that are climbing telephone poles and cutting trees down. So an active job like you described, you're probably looking at about that 2 month window.
That seems doable. And what about driving? When can a patient start to drive again?
So this is being recorded for posterity. So I'm sure there's legal review. And that, again, it mostly depends on how well you're doing as a patient. I think the pamphlet we give out says don't drive for a month or two. But I'll tell you, it depends on you as the patient. The folks that have stronger legs and are feeling better, we have some folks driving at 2 weeks. But I will say this is non-negotiable. You need to be off your narcotic medication. So often after surgery, or not often, vast majority of the time we'll have you on narcotics for 1 to 2 weeks after replacement. And so you shouldn't drive if you're ever taking narcotic medication because that can mess with us mentally.
Great advice. So this attendee is probably going to want you to maybe go a little bit more into detail on the same day surgery. They said that they had a total hip replacement approximately 5 years ago, now needing the left. With the past surgery, they had it at 8 a.m. and was heading home by 1 p.m. So maybe talk a little bit more about what those requirements are to have the same day surgery option to go home in the afternoon.
Good. Yeah. And happy to talk about that as much as we need to. Like we've mentioned, we were the first group to start that years ago here in Indiana. And now we teach classes across the US and Europe and other places. A lot of it depends on the patient and the family support. That's a big concern. You know, folks that live alone, we don't really feel like that's a great idea to go home the same day by yourself. Actually, surgeons have different opinion, but I don't let folks do that. So again, it depends on your pre-surgery strength and mobility. That's a big key. Your family support, and then medically. A lot of it depends on medical comorbidities, is the fancy doctor word. You know, folks with a really bad heart or bad lungs, well, maybe we should keep you overnight in the hospital to keep an eye on those things. But again, if your health is overall very good and our pre-surgery screening exam confirms that, and a patient wants to and is motivated, we will let you plan on going home the same day. Now, in my practice, even if we're planning on going home the same day, I always reserve you a night just in case. It's like a hotel. It's easier to cancel it if we don't need it. And don't worry, you don't get dinged for that. That's just on our end. We always have that space reserved just in case.
I like that plan. That really shows you guys take care of your patients. I'm not sure if you can comment on this or not, but one of our questions that came through is what anesthesia is used for the surgery?
Oh, yes, we sure can. I will say this, our before surgery, within a month of surgery, we have you see our impact doctors. And this crew of men and women are fantastic on helping pre-screen patients. The goal is surgery to be smooth and effective, and we don't want any road bumps. And the pre-screen is very helpful, and our internal docs do a great job. And with that visit, that helps not only me, but also helps our anesthesiologists who review your surgery case. They review the cases the week ahead of time. And so what I mean to say is they individualize your anesthesia. Now, for the most part, patients get some sleepy medicine and an LMA. Often they'll get a short-acting spinal and then a local block inside the joint, whichever part of your knee or hip is being replaced.
Great. And then you kind of answered another question that came through asking if you use an epidural. So it sounds like they'll get a couple different injections.
Correct. And it sounds like, what does all this mean? Well, it's called multimodal analgesia. And we've learned that if we prevent pain, like prevent the pain fibers from getting ramped up, that when the numbing medicine wears off, your pain won't be as great. Whereas if, you don't have good anesthetic and you cut someone's skin or do what we do for surgery, the pain fibers can get revved up, and we certainly can handle that, but it just takes much longer to get the pain under control. Like 20 years ago, we had people on the pain pumps and they were on narcotic pills for up to a month. Well, or even 2 months. Now that would be very, very unusual, because I think we as surgeons, as well as our expert anesthesia and our pre-screening with our internists, again, a team approach that really helps us improve the outcome right after surgery and for weeks after the surgery.
The next question is, can you do the surgery in Northwest Indiana?
I think I know what that question means. Can I do it in Northwest Indiana? I can do the surgery anywhere. I mean, I've operated in China and South America or wherever, but that's not where I operate down here in Mooresville, because that's where we feel like our team gets us the best chances of helping you as the patient. Now, if the question means, will your insurance let you visit a surgeon in Northwest Indiana, that'd be something to check with the insurance team.
Correct. But our surgeons are down in Mooresville. So if you want to see one of our guys, you'll have to come see us there, but we'll take good care of you.
Well, and in that regard, we do know that it's a pain sometimes when folks are driving. So we do try to minimize the driving amounts.
Right.
Because we have folks from Illinois and Michigan and Kentucky, and heck, we even have folks come from Alaska and Vegas. And we try to minimize and do things as much as we can on the phone or via telemedicine. But it does help to see each other face to face time to time as well.
Right. And then for the rehab post-surgery, they would then be able to do rehab closer to home or in home if they choose. Is that correct?
Absolutely. The post-surgery therapy is always near home, whatever's most convenient, because if the therapist isn't sure what we want, we will talk to them and communicate with them so we're all on the same page.
Great. This question that came through says, I'm having trouble with pain meds. I can't do many of them. I'm assuming there is pain med counseling. Is tramadol enough to handle the pain?
So good question. We do see this from time to time, and I don't have a great answer yet, other than what we generally will do for patients that can't tolerate call it the regular narcotics, what we usually give for that week or two after surgery. We usually will try to find a pain doc or a family doctor near you and try to do testing ahead of time to see, well, is it a true allergy? Then we can't use it. Is it the side effects of the medicine? Well, can we combat those side effects? Like there's some patients that get nausea. Well, maybe if we give an anti-nausea medicine, we can tolerate the pain medicine for that week or so. Or otherwise, sometimes we just can't give them, and we have to have alternative medicines that the pain teams have access to. Tramadol, I've had a few patients where tramadol or even just Tylenol have been okay to deal with the post-surgery pain, but that's few and far between.
Great. And then the last question that I'm going to serve you up, unless some more come through, is what should they look for in a surgeon? Just talk a little bit about what's important to find in a surgeon to feel comfortable to go through with the surgery.
That's a good question. And I mean, it's like me trying to look for a mechanic. I know a little about cars, but not a lot. And a lot of it, one, you want to visit them, bring your family with you, feel comfortable with the interaction. That's probably most important. But in our world, a lot of folks don't realize, but there's orthopedic surgeon, well, there's doctors, there's orthopedic surgeons, and then there's hip and knee replacement specialists. And so if a surgeon's fellowship trained, that means they've taken even extra time to hone in on the hip and knee replacement. That doesn't necessarily mean that he or she will be great. And it doesn't mean that someone that's not fellowship trained is not great. Meaning I've met folks on either end of the spectrum, but fellowship trained is a big quality measure for most of us, not every one of us. Then meeting your surgeon and asking your specific questions of your expectations before and after surgery. And I'll tell the number one thing as a patient to check on your x-rays. When you're in the room, if you're bone on bone, replacement's a good option. If you're not bone on bone, replacement generally is not a good option just yet. Meaning some patients do have pain, but they're not bone on bone. Knee replacement or hip replacement doesn't fix every hip or knee pain. It fixes bone on bone arthritis pain. And that's what the surgeon's there to hopefully help distinguish for you.
Wonderful. I love hearing you talk about that, because I know that it's important to really take that choice seriously when looking for a surgeon for these procedures. I do not see any additional questions, so I think we will go ahead and wrap up. Just a reminder, if you do feel like you're ready for an appointment, please let me know in the chat box, and we can connect you with our scheduling team, and they'll get you in as soon as we can. We'll give you priority scheduling for being with us today. So thank you, Dr. Malinczak, for being here and for giving this great overview. The question and answer session was wonderful as well. We are recording, so we will send out the recording here in a few days once we have that. But thank you so much, everybody, for being here, and I hope that you guys all have a blessed day.
Great, and thank Kayla, if you have if there's 1 second, I'd like to, thank the Purdue folks. We know driving from Lafayette down to Mooresville can be a bit tedious or long, but we do try to be cognizant of that and minimize your back and forth and communicate as best we can. Thanks, guys.